All right. Welcome, everybody. We appreciate you joining us today. Uh, we're here to talk about DPP-1 inhibitors for bronchiectasis. And we're very grateful to have Dr. Ann O'Donnell from Georgetown University with us today. So a little bit about the organizations that are hosting this. If you're not familiar with Running on Air, we are a nonprofit, and our mission is to help others breathe more easily through access to oxygen appropriate to their needs. We focus on primary ciliary dyskinesia and bronchiectasis lung diseases, NTM also. And in particular, though, we focus on supplemental oxygen. And you can see our social media links to the right. We put webinars like this on periodically. And here's a list of the webinars that we will be hosting next year. These are still in the works, and 3 that we're going to be having at the end of this year. So, keep an eye out for those. You can find those on our social media or on our website, also in our newsletter. So moderating with me today is Amy Leitman, who is the president of NTM Info and Research. Thanks for being with us, Amy.
Thank you for having us here today, Mary. It's great to be here. Welcome, everybody. We'd like to welcome you. So as you know, August 4th is World NTM Awareness Day, but we kind of celebrate throughout the whole month of August. I'd like to tell you a little bit more about NTM Info and Research. We've been around for more than 20 years supporting patients with NTM lung disease and bronchiectasis. We have a number of resources to support patients. We have a wonderful support group network. If you are looking for a support group network, a support group in your area, you can contact us. If there isn't one and you'd like to start one, you can also contact us. We have resources for that as well. We have NTM-BE Connect, which is our online patient forum for NTM and bronchiectasis patients. We have a terrific YouTube channel with over 120 videos of various webinars and conference videos. We also give out our free pamphlet, which is called Insight, A Patient's Perspective, which is a great resource for patients with NTM. If you'd like a copy, you can contact our office and we'll be happy to send those to you. So we have another webinar coming up on September 10th. We will be having several guest speakers from Yale University Medical Center. We have Dr. Ashley Lozier, Dr. Sebastian Kurtz, and Marjorie Cullinan. They've spoken for us before and it was very well received. So they are going to be speaking this year, September 10th at 4 p.m. Eastern on living well with NTM and bronchiectasis, airway clearance, and more. You can see the QR code there to register. You can also log on to our websites and you'll find the registration link there. And we are bringing that to you again in partnership with Running on Air. So we're very grateful that we can continue to bring these webinars and to you throughout the year. And we'd like to thank all of our sponsors who've been supporting our efforts throughout the year. They make all of this programming possible and we appreciate their support. We appreciate you guys showing up every time. Thank you.
I also want to add, you will be receiving an email either tonight or tomorrow morning after the webinar, and it'll have links that we've talked about in the webinar, and we'll send you this link also to make it a little easier to register if you don't like using QR codes. So just a little disclaimer. We just want to make sure everybody knows that this webinar is being offered strictly for informational purposes. Dr. O'Donnell is not giving medical advice to you. You're not her patient. And even though I am actually her patient, she wouldn't be giving medical advice to me during a webinar like this. So we just felt it was important that everybody understands what the DPP-1 inhibitors do. And, just so you can be better informed for making some decisions with your own doctor as to whether some of these medications or some of the trials that are being discussed might benefit you. And we also just want to say that there is no company sponsoring this particular webinar or has had any part in the content of this webinar. And just as a disclosure, we want to let everybody know that we have received money from Insamed and Boehringer Ingelheim, both running on air and TMIR, for other sponsorship opportunities. But again, they have had no connection with this webinar or effect on the content that we have that we're sharing today. And a few housekeeping items. So this webinar is being recorded, and we will share that recording once it is up online. We will not be taking questions during the webinar. So if you raise your hand, we're not going to stop to answer your questions. There is a Q&A, so I recommend that if you do have a question as the webinar goes along, that you put your question in at that time. And at the end of the webinar, we will get to as many as we can. And as I said, Dr. O'Donnell cannot give personal medical advice. So again, we appreciate Dr. O'Donnell being here today. She is a professor of medicine at Georgetown University and chief of the Division of Pulmonary Critical Care and Sleep Medicine at Medstar Georgetown University Hospital, as well as the Naive and Naomi Cohen Chair in Pulmonary Disease Research. And Dr. O'Donnell, you are also currently acting medical director at Georgetown?
Chairman of the Department of Medicine.
There we go. So in other words, she hasn't slept in several months. She's authored over 40 manuscripts. Dr. O'Donnell is an internationally recognized expert in bronchiectasis and respiratory infections. She's spoken at many international conferences on these topics, and she has been a principal investigator on numerous clinical trials investigating new therapies for bronchiectasis and NTM infections. All right. Thank you, Dr. O'Donnell.
All right, thank you. Let me just get these slides teed up. There we go. Everybody can see my slides? Okay, we good?
Yes.
Great. Okay. So I really want to thank Mary and Amy and colleagues there for inviting me to do this. I really appreciate everybody attending this. It's late August, right before Labor Day, and I know you have a lot of things to do. So I'm looking forward to the interaction from this webinar. So I do want to say, as Mary just mentioned, that although I have received consulting fees for advising, and I've been the PI on the principal investigator on a number of clinical trials, particularly the things we're going to talk about today, I am not being compensated at all by the companies or speaking for any particular company. And I'm really here at the invitation of NTMIR and running on air on Mary Kitlowski and Amy Liebman. I have absolutely no financial interest in these companies, and I'm hoping I'll give you an overview of where things stand with new therapeutics, particularly with Bronchiectasis. So I thought just my objectives today really, I'm just going to briefly give what I call my Bronchiectasis 101 short course on terminology and what we consider standard therapies right now in bronchiectasis. I know people on this webinar come from different, places in their disease and their understanding of the disease. So I do want to just give a little bit of background that's going to be relevant to helping to understand the outcome of these clinical trials. I know we all know and why we're here, because we have so many unmet needs for patients with bronchiectasis. We also know that, this is the first, Bronchiectasis is the first FDA-approved treatment for bronchiectasis. So it's really opening the door to a whole new era of treatment for our disease. I am going to focus on, the data on Bronchiectasis and the reason that the FDA has approved it, but I will briefly mention some other clinical trials and other drugs that are in the pipeline for bronchiectasis. So we all know the vicious cycle, the vicious vortex, the reason why patients get bronchiectasis, that there's some initial insult to the lung, either an inhalation injury or a prior infection. This sets up a process of inflammation that's generally driven by white blood cells called neutrophils. Those neutrophils create proteases that help injure the lungs, injure the airways, and cause destruction of the airways and distortion. And that destruction, distortion, irregularity of the airways is what is bronchiectasis. Because the airways get thicker walled and get enlarged or dilated, they accumulate mucus. We all make mucus in our lungs, in our airways, but when the airways are not normal, the mucus tends to stagnate and accumulate in those airways. And that stasis of the airways is really a fertile ground for bacteria to grow. And then, if this cycle is left uninterrupted, it just gets worse and worse, the so-called vicious cycle. Your airways get plugged up with mucus. So the definition of bronchiectasis is abnormal enlargement of the small airways. And it's characterized by thickening of the walls of the bronchi. The bronchi turn ectatic or irregular. As I said, mucus gets retained, and that sets off this vicious cycle of inflammation, infection, and destruction. And really, bronchiectasis is a pretty simple diagnosis to make, because CT scan is the confirmatory test. But of course, we know that many patients struggle to get to that point of getting that CT scan to make the diagnosis. And there are other important tests that we do: blood counts, immunoglobulin levels, testing for congenital diseases, pulmonary function tests, and cultures. So, this is just a visual, right, of in the old days, older than me, that what used to be done is instilling contrast right into the trachea to outline the abnormal bronchi. But now, fortunately, we have CT imaging. But just sort of the basic anatomy: you have your main trachea, which branches into the large bronchi, and then just like tree branches, the airways get smaller and smaller as they get out towards the edges of the lung. And it's when those distal or far out airways get enlarged, that's when you have bronchiectasis. And of course, this is the CT, several different CTs that kind of lined up with anatomic findings. This is obviously a slice of lung. The patient has bronchiectasis here. There's this large airways. And this is exactly what we're seeing on the CT. So CT is just the most vital part of the diagnostic algorithm in order to confirm the diagnosis. So you can see these airways are larger, thick-walled, and then they're plugged up with mucus, and there's some extra blood flow around them, and that's often why patients also cough up blood in this disease. So lots of different ways the bronchiectasis shows up, but I just want to really, drive the point home that the CT is diagnostic of the bronchiectasis. I also want everybody to understand that the bronchiectasis is the anatomic abnormality in your lungs, in your airways. And then bacteria get into those airways. So, not everybody with bronchiectasis, for example, has Pseudomonas. Not everybody has NTM. Those things are distinct, although obviously related. And generally, the bronchiectasis comes first, and then comes the infections. And again, 3 main types of infections in addition to viral infections. So routine bacteria, non-tuberculous mycobacteria, and other names for that are acid-fast bacteria, mycobacteria, and then fungi. Now, why do people get bronchiectasis? A lot of times we don't actually know why it happens to you, but it's often a complication of pneumonia. It can be seen in patients with COPD or asthma. Reflux or aspiration can be a cause. And then there's other, like autoimmune diseases and congenital disorders, that can more rarely cause bronchiectasis. So another really important take-home message in order to understand the data from these recent clinical trials is the word exacerbation or flare-up. And I really want everybody to understand, because this is really important for really planning treatment and deciding whether a new therapeutic is a good option for you. So an exacerbation is basically an increase in your baseline symptoms. And we've come up with a sort of consensus definition for clinical trials, but it fits for patient care as well. So if you have 3 or more of the symptoms listed here that have increased and have been increased and for at least 48 hours, that's what defines an exacerbation or a flare-up. So increased cough, increased volume of your sputum, or change in the consistency of your sputum, purulence, green, dark sputum, being breathless, being more fatigued than usual, or coughing up blood. So the idea is that's what you as a patient really need to pay attention to in the course of your disease, because a lot of what we're going to talk about really revolves around understanding this diagnosis of exacerbation. And really, we as clinicians have to really train our patients to call us when they're having an exacerbation. And we need to respond to those queries in a timely fashion. We need to know what the patient's status is in terms of the extent of their disease and what their cultures show. And again, duration and how long we treat them for. Just a word about the bacteria and this idea of, gradually more purulent sputum, as you see in this color chart here. About a third of patients worldwide with bronchiectasis have Pseudomonas, and another common bacteria is Haemophilus. I know many of you on this call have non-tuberculous mycobacterial infection. We're going to touch on that a little bit later. It varies in its frequency depending upon where in the world that you live. But this color chart is actually very helpful, I think, for patients to kind of get that in your head. And the more dark, the more green, brown, or bloody the sputum is, the more likely you're having an exacerbation of your bacterial infection. So there's a lot of unmet needs, as I alluded to. What we're learning a lot in our recent investigations is that patients have different traits. They have different what we call phenotypes, which means that one patient may have exacerbation characterized by a lot more sputum and blood. Another might be more wheezy or short of breath. And so we really need to approach each patient in a very personalized manner so that we can prescribe the right treatment. And we really are trying here to get your day-to-day symptoms under better control, and also to prevent more damage and potentially reverse damage to your lungs. A brief word on how drugs get approved by the FDA. This drug discovery is a very complex process. In the case of the drug we're going to talk about, Bronchiectasis, it was discovered by a company many years ago and actually came to initial testing in 2016. So, it's 9 years from identification as a possible agent to actually getting it through the process. So there's preclinical research, there's testing on patients, phase 1 testing just to assure safety in normal volunteers, to phase 2, and then phase 3, which are the more pivotal trials to get it approved by the FDA. So it's a process, it takes a long time, and we've been waiting a long time in bronchiectasis to get to this point. So I think that's, really a reason to have great hope and great gratitude right now for the fact that drug development is progressing in this disease. So what the FDA wants is that the drugs that they approve should be safe and effective. And effective means the drug improves how patients feel, function, and survive. And there's been a lot of webinars and connectivity between patient populations, like in mycobacterial disease, and the FDA, and with scientists and clinician trialists to get to good outcomes and endpoints for these clinical trials. So right now, the treatment of bronchiectasis is aimed at all aspects of the vicious cycle or the vicious vortex. So we want to treat the underlying disease if you can mitigate that. We want to do airway clearance, and I'm sure most of you are familiar with the idea of mechanical airway clearance with devices and pharmacologic airway clearance, usually with hypertonic saline. Next step up on the treatment is to reduce the inflammation. And traditionally, we've used macrolides and inhaled corticosteroids for that. But really what we're going to talk about today is opening a whole new world of anti-inflammation treatment. And then the next step up is really antibiotics targeted to the organisms that you have. And if you do have an exacerbation, to go ahead and treat the exacerbation. And there is a school of thought about eradicating the first time you culture Pseudomonas. So again, exacerbation, I think we're all together now on understanding what an exacerbation is. Why are exacerbations important? Because the more frequent you have an exacerbation or a flare-up of your disease, particularly if it's more than 2 or 3 times per year, you're more likely to be hospitalized or need IV antibiotic therapy. Patients who frequently exacerbate or have worse quality of life, more symptoms, more inflammation, more significant infections. There's a higher 5-year mortality. And so it's a real priority to get these exacerbations under control. Now, I know patients don't really come into me and say, hey, I want to reduce my exacerbations. You know, they say, I want to feel better. I want to have less symptoms. But really want you to understand how important it is that we prevent these flare-ups that require more intensive therapies. So we think, and this is work from James Chalmers' group in the UK, that the initial insult, there may be reversibility to the initial bronchiectasis insult, but we have to be able to recognize that. The intermediate stages is when things start to cycle out of control, and the late stages when there's the established bronchiectasis and the self-sustaining vicious cycle, vicious vortex going on. So what are we here to talk about? And this is, you know, of course, the news of the last 2 weeks is that we now have this approved drug that treats neutrophilic inflammation in patients with bronchiectasis. So the drug we're going to speak mostly about is Bronchiectasis, which is the one approved 2 weeks ago by the FDA. I am going to briefly talk about some other agents in the pipeline that are maybe effective against neutrophilic inflammation. There's also work being done on patients. A smaller percent of patients with bronchiectasis have more of an asthmatic, eosinophilic inflammatory profile. And I'm going to just mention a few other things in the antibiotic world and airway clearance. So how did Bronchiectasis get to the point of being approved by the FDA? In 2020, the phase 2 trial, so the trial that was done to really look at safety and to some extent efficacy, was published in the New England Journal of Medicine. And this trial enrolled over 400 patients. It was what we call a randomized double-blind controlled trial. It compared 10 milligrams of this drug to 25 milligrams to placebo. And what was found in this phase 2 trial was a reduction in the number of exacerbations over a 180-day period of observation of these patients. So the 10 and 25 milligram doses of the Bronchiectasis reduced exacerbations compared to patients who were receiving placebo. Now, part of the thing in phase 2 trials is kind of to prove, why does the drug work, right? Phase 3 trials are more like, does it work? But phase 2 is more the scientific side of the study to understand mechanistically why the drug works. And in this slide, this is the level of neutrophil, sputum neutrophil elastase. And you can see the placebo arm up top, there really was no change during the course of the trial, but there was a significant decrease in the neutrophil elastase levels in both doses of the Bronchiectasis. So that proves mechanistically that the drug does what it's supposed to do, which is reduce a level of neutrophil elastase, which is the bad actor in the airways, one of the bad actors. So this led to the publication of the phase 3 trial, which came out in April of this year. And I'm going to go through this in a little bit more detail so we all understand how this drug actually got to approval. So the pivotal trial, this phase III trial called the Aspen trial, enrolled 1,721 patients, mostly adults with a handful of adolescents in the trial. Again, the way this trial was set up, 1/3 of the subjects got a placebo, 1/3 got the 10 milligram dose, and the other third got the 25 milligram dose. This was a 1-year trial. And the primary endpoint of this trial was to see if there was a reduction in exacerbations during treatment. When studies are set up like this, there's one primary endpoint, and then there's what's called the secondary endpoints, which are other, other clinical things of interest to us, like how quickly did patients exacerbate, what percentage of patients remained exacerbation-free while on the drug compared to placebo, was there a change in lung function, was there a change in severe exacerbations, and importantly, did patients feel better on the drug? And that in this trial, what was used was a symptom score called the Quality of Life Bronchiectasis, or the QLB. So here's who was in this trial. The mean age across the 3 arms of the trial was 60 years. About 2/3 of the patients were women, which is reflective of what happens, in the real world of this disease. You can see the ethnic group and race breakdown. And about 1/3 of the patients were chronically infected with Pseudomonas. Now, to get into this trial, you had to have had 2 exacerbations in the past 12 months. So that was the baseline to get into the trial. So it wasn't patients who were, well over the past year. They had to have had 2 exacerbations that required antibiotics over the 12 months prior to enrollment. So about 70% had 2, and about 30% of the patients enrolled had 3 or more exacerbations. And this schematic shows, the 25 versus the 10 versus placebo dose. And basically the bottom line primary endpoint was achieved. And there was about a 21% reduction in exacerbations in the 10 milligram dose, a 19.4% reduction in the higher dose compared to the placebo. So this trial met its primary endpoint in terms of reducing exacerbations. And this is, again, the graph that shows that the improvement does not happen right away. That's very important to know. So you can see here, this on the y-axis is the number of exacerbations, and on the x-axis is the weeks since starting the trial drug. And you can see that the lines don't really separate until about 24 weeks. So it takes time for this drug to work in your lungs to reduce the level of neutrophil elastase. But then at the 24-week mark, we can see the placebo group, clearly had more exacerbations, and the 2 doses of the Brenzo showed a reduction in exacerbations. So this, is very exciting news, because we've never had a drug that has done this before in a clinical trial. So just to put it in perspective, the placebo patients have 1.29 annualized exacerbations, and the study group had a smaller number. And in terms of these secondary endpoints, I would say the most important ones that came out positive was the exacerbation-free, so patients who went through the whole trial on the study drug and did not exacerbate. The other really kind of important result here was the reduction in lung function that happens normally was altered. So patients who received the active drug actually had a slower decline in their FEV1, their lung function measure, over the course of the trial. And the other really important thing is that based on that quality of life questionnaire, there was an improvement in patient symptoms on the 2 arms of the active arms versus the placebo. And of course, the other key thing that we all care about is this drug safe? And a lot of emphasis on safety was in the phase 2 trial, and then in the phase 3 trial, it held up that there was no difference in significant adverse effects across these treatment groups. The one thing that was of particular interest was this possibility that this drug might cause what's called hyperkeratosis. And it turned out there was a slight increase in patients who received the drug, but it was a very small and not statistically significant difference in this skin thickening phenomenon that can come with reduction in neutrophil elastase. So, who should get this drug? What dose is the 10 versus the 25 milligrams? What dose? Is it safe? And what does the FDA say? So the FDA on August 12th says that it's indicated for the treatment of bronchiectasis in adults and adolescents. They did not put any restrictions on how frequent the exacerbations needed to be or anything like that. They just approved it, as you can see right here. So what I thought I'd do was run through a few different patient scenarios and sort of give, again, my opinion based on my understanding of all of these results, like what patient really would benefit from this drug. So here's a patient, who has radiographically mild to moderate bronchiectasis in both of their lungs. This patient has chronic infection with Pseudomonas. Despite doing all the standard therapies like airway clearance, azithromycin 3 times a week, or chronic inhaled antibiotics. So this patient, again, a frequent exacerbator despite receiving standard therapy. And this patient clearly would fit the criteria that we saw in the trial, right? She has more than 2 exacerbations. So this is clearly, in my mind, a patient who could potentially benefit from use of brensocatib and get that reduction in the exacerbations. Now, what about patient 2 here? And I know, many of my patients fit into this category. They have nodular bronchiectasis. The only bug they ever grow is Mycobacterium avium complex. No Pseudomonas, no Haemophilus, no routine bacteria. And this patient is on MAC antibiotics. There are no exacerbations for this patient because it's actually pretty rare for people who are just infected with Mycobacterium to truly exacerbate. But the patient has daily cough and sputum production. And I know many of you are wondering about this. I mean, this kind of patient was actually specifically excluded from the clinical trials. We were not allowed to enroll patients with MAC infections who are on antibiotics in this trial. So I think we really don't know yet, and I'm hoping that we're going to do some kind of trial to figure this out. And the sort of classic MAC patient, is there a role for brensocatib? And again, we really don't know the answer to that. Okay, what about a patient like this? Many of you, I'm sure, fit into this category where you have the disease, no question. Your bacteria usually is Haemophilus, and you're on the standard therapy, as I already said, and you have 1 exacerbation every 2 years. So a patient like this, should this patient get brensocatib? And I think this is an open question. This is a patient who's symptomatic, clearly has the disease, but does not frequently exacerbate. And again, we don't know the answer to this based on the clinical trials to date. And I think this would be an individualized decision between the patient and their physician. Now, what about a patient who has severe bronchiectasis and who's got both Pseudomonas and MAC and is on stable standard therapy that I've already mentioned and on chronic infections? Again, this is a patient that I think we would consider using brensocatib, but the data from the trials does not give us the answer to this. So again, an individualized decision. All right, what about patients who just get diagnosed with bronchiectasis because they've had a CT scan for other reasons, right? I mean, I'm seeing this more and more. Patients come in because they've had a CT scan done to do calcium scores on their heart, on the coronary arteries, and they pick up a little bit of bronchiectasis. And many of these patients really are totally asymptomatic or, have an occasional cough, and we don't find any positive cultures. There's, in my mind, this is not an indication to use this drug at this time, but I think we need to find out if Brenzo and its companion drugs actually may alter or reverse bronchiectasis. I'm not saying that it does, but I think this is an area that's going to be ripe for further investigation. And finally, and I bet some of you are in this scenario where you have bronchiectasis, but you also have an underlying autoimmune disease, say rheumatoid arthritis, and you're on a biologic therapy, and you have regular bacteria and you have Mycobacterium abscessus infection, and you're on treatment for all of those things. This is a tricky question because this patient is technically immunocompromised on a biologic therapy for rheumatoid arthritis. And we really don't know if altering the milieu of the neutrophil in the lungs might, be positive for this patient or might be a concern. So I think many of us have a little bit of concern about patients who are immunocompromised and whether this drug is safe, because of course we didn't enroll patients like this in the trial. So I just want to conclude with a couple of other things to just let everybody know that what other new therapeutics are in the pipeline. There are 2 other neutrophil elastase inhibitors that are in clinical trials that are similar to brensocatib. There are trials right now looking at the role of treating the eosinophilic inflammation in the disease. And there's some new drugs in development for airway clearance, antibiotics, treating infections, and better personalizing treatments. So, we're really only scratching at the surface of our understanding of what actually goes on at the level of the airway, with the cilia, with the mucus layer, with the inflammatory cells that are active. So there's lots of potential targets ultimately for new therapeutics beyond the DPP-1 inhibitors. So this is one other DPP-1 inhibitor, cathepsin C inhibition. This trial has now been published. This is the phase 2 trial of this drug, which now has a name, verducatab. And it showed a similar result in phase 2 to what was seen with the brensocatib phase 2. So there is a phase 3 trial coming on this drug, BI 129-1583, recently renamed verducatab. It probably will be available to many of you because it's going to have sites around the US. There is a third DPP-1 inhibitor called HSK 31858. This phase 2 study was done in China. It was a typical phase 2 trial with 226 patients. It also showed positive results, was published earlier this year in Lancet Respiratory Medicine. And this is going to come to a phase 3 trial internationally as well. Just to highlight again, about 22% of patients with bronchiectasis have a more eosinophilic inflammation type, where their blood eosinophils are greater than or equal to 300. And there's been some observational reports of success with the quote unquote asthma biologic therapies in this disorder, and clinical trials are coming for this as well. A couple of new agents for clearing the airways that have gone through phase 2, very small studies that may eventually come to a wider investigation to see if we can do better in terms of just mobilizing the mucus. And another antibiotic in the pipeline, if you will, although used off-label here in the US, is inhaled colistin. The data from that was published last year, kind of a mixed bag of results, but again, an antibiotic that may come eventually into use more widely in the US. And phages, patients always ask about phages. There's just very limited data so far on using phages in bronchiectasis. There is a trial right now with the drug called ensifentrine, which is approved in the US for treatment of COPD as a way to reduce exacerbations. And this trial is enrolling in different parts of the US and internationally as well. And another study that has just come out is using a totally different approach, a monoclonal antibody against Pseudomonas. Again, a small phase 2 trial, and more to come on that. I already mentioned that one. And finally, investigation into the role of looking for and finding not cystic fibrosis, but cystic fibrosis type patients with quote unquote non-cystic fibrosis bronchiectasis. So more to come on this, because right now we just really have observational reports on using these in certain patients with bronchiectasis. So again, here's the just a snapshot of a couple of trials that are enrolling right now in patients with bronchiectasis. So to conclude, I would say that this is obviously very hopeful that we have the DPP-1 inhibitors, both the one now approved and the ones that are going to undergo further study. There's a lot of unmet needs in this disease. We need better education for our clinicians to diagnose this, for our patients to understand the ramifications of bronchiectasis. We need greater clarity on the cause and prognosis and good self-management strategies, and stressing the importance of physical activity like Mary's group running on air. So right now, again, I do want to stress how important it is that the DPP-1 inhibitor is really only one part of the treatment strategy. It's not like it's going to be the be-all and end-all treatment and eliminate the need for addressing the airway clearance, treating the infections, keeping the patient active. It really touches on only one aspect here of the vicious cycle or the vicious vortex. And we really need to stress how important it is that patients, stick with the plan, airway clearance, treating infections, treating inflammation with other drugs, that this is not the whole story. This is one new part of the puzzle. It's really exciting because if you look at this diagram back in until like the really 1990s, 2000s, but really more recent, there's just been much more scientific investigation into the disease of bronchiectasis. And so the new therapeutics are really exciting. I think, again, the fact that we have brensocatib approved now by the FDA is just such an important milestone. I've been doing clinical trials in this disease since the 1990s, and this is really the first true success. But we really need to understand better, which patient truly benefits from it, where to add it in that step-up approach to treating the patients, where to place it, vis-a-vis the other things that we talked about. And really importantly, we just really don't have a good handle on patients with non-tuberculous mycobacterial infections and the use of this drug. So, it's on us as the clinicians and researchers, and on our patients as advocates, that we go ahead and pursue further clinical trials in this disease. I really want to, encourage you to, speak with your physicians about this drug, and obviously to help you understand your disease in general, and really appreciate the idea that we want to reduce exacerbations, we want to make patients feel better, and this really adds an important component to our armamentarium. This is my team here at Georgetown. We're one of the clinical care network sites for bronchiectasis and NTM care, and we have a number of active clinical trials. And again, I want to shout out to Mary running on air, to Amy and her team at NTM-IR, and to the Bronchiectasis and NTM Association, and most importantly to our patients who have done such a good job in advocating for better approaches to this disease. So thank you, and I will turn it back to Mary and Amy.
Thank you, Dr. O'Donnell. So before we move on to the question and answer, Amy and I have a little bit more we want to say about drugs and new drugs coming in the pipeline in general. And there have been a lot of questions about the costs and how do you get the drug. So Amy's going to start us off.
Sure. So with respect to the costs, I think at this point, it's really a question of your insurance coverage. That question's just up in the air at this point. And it's going to vary from person to person, depending on your co-pays, your coverage. But one of the questions we get a lot is how do you get the drugs? So with the drugs that have been developed specifically more recently for NTM and for bronchiectasis, they're available. You can't walk into a Walgreens or a CVS and get them. They're available through a network of specialty pharmacies, and in this case, a network of specialty pharmacies that specialize in rare diseases. So what happens is that the drug manufacturer selects the specialty pharmacies that are going to be the network that provides these drugs. They usually, select several of them so that there's as broad a coverage as possible for, insurance providers. Usually what happens is there's a prescription form. The prescription form, either the institution or doctor that's prescribing it, or it will get sent over to either the institution or the prescriber has already figured out which of the specialty pharmacies falls under the patient's insurance, or it gets kicked over to this central hub, which then looks at the patient's insurance and, okay, these are the pharmacies that carry this drug, and this is the pharmacy that this patient's insurance works with. So that's kind of the system of how it goes. And that's sort of the broad level explanation. Rare specialty pharmacy is sort of a separate and special animal. And it's something that, I think we're getting more familiar with as well as more gets developed for our patients. So we are working on putting together a webinar for later this year that will just sort of provide a lot more insight into how these specialty pharmacies work, because I think there's just this perception that everything works like the way, a Walgreens specialty pharmacy works or CVS specialty pharmacy works. And those are one kind of specialty pharma, but there are different kinds as well that are smaller, that sort of focus more on specific rare diseases. And that's kind of the space that we fall into right now. So that's something that we're going to be working on putting together so that our patients have a better understanding of it. But just so you understand, let's say your doctor checks off a specific, one of the, specialty pharmacies for, your new prescription for brensocatib, and then sends it off. If it goes to that pharmacy and it turns out that's not the pharmacy in your network, it will get kicked over to the hub, or if they know which one it should get kicked over, they'll send it over to that pharmacy. So, they have the ways to figure that out. They know which insurers work with which one. It's a relatively small network. But we'll be getting into more of that as we put together a webinar, because I think it'll be worthwhile for everybody to understand the process. Because this is going to be, I think, a much bigger part of everybody's life going forward.
All right. Thanks, Amy. And I just want to remind everybody, I see a few people have raised their hands. We're not calling on people who raise their hands. If you have a question, please put it in the Q&A, and we'll get to as many as we can. And based on the number in there right now, we won't get to all of them, but we'll see if we can get your questions answered at another time. And before we continue on to the Q&A, I will be sharing quickly. Sorry, bear with me for a moment. Okay, so there have been, I've seen online and social media groups questions about the costs and how to afford the medications. So I just wanted to throw a few things out for people to look into for what might help. And as Amy said, we really don't know. It's going to be based on your insurance, what it comes down to. But if you are on Medicare Part D, the basics of Medicare Part D, it covers most outpatient prescriptions. And the coverage will depend on whether the medication is part of your Part D plan's formulary. And if you don't know what a formulary is, it's basically the list of drugs that the plan covers. So if you've ever had your insurance say, well, we won't cover this drug, but there's this other one that's similar and we do cover that. That's because the first drug wasn't on the formulary, but the second one was. And every plan has a different formulary. Even if you have a Blue Cross Blue Shield plan, every single Blue Cross Blue Shield plan pretty much has differences in their formulary. The maximum amount you will pay out of pocket for drugs that are covered by Part D is $2,000 for 2025. And that gets adjusted every year. It may be the same for 2026, I don't know. But for 2025, that's the maximum. But again, it's for drugs that are covered. So if you're paying for a drug out of pocket that's not covered, that does not go towards the $2,000. And that also does not include premiums that you pay for your Part D coverage. So Medicare Part D does have a prescription payment plan. So it offers a way to spread your prescription costs throughout a year. So all Medicare drug plans or Medicare health plans that have drug coverage offer this payment plan. Participation is voluntary. You must enroll, and you enroll through your plan. And you can enroll anytime during the year, and there's no cost to enroll. The payments might not be the same amount throughout the year. So the payments, depending, can vary, and I'm going to show some quick examples. And the first month of enrollment is calculated on the maximum possible payment calculation. So my understanding, and again, I also just want to say, I am not an expert in this. So if you're confused, we're going to have some links that you can get more information. But, these are just suggestions for you to look into to help if you're concerned about the cost of any of your medications or all of your medications combined. And then the remaining months are calculated based on what remains from the previous month, plus whatever new costs you've incurred that month. So if you do enroll in this plan, you won't pay the pharmacy when you pick up your prescriptions. What will happen is the plan will send you a bill. Now, I tried to find out how long it would take once you applied to actually be enrolled in the plan, and it may just vary on the plans. So I don't have an answer to that. But the plan does not save you any money. You're still going to spend $2,000. Well, you won't spend more than $2,000. It's not reducing any of your drug costs. But if you do have expensive medications, or maybe you have a situation of, say, an exacerbation, and you have a lot of expenses for medication in 1 month, this could help spread it out throughout the year. All right, so the first example here is if you're starting payments in January, and the cost of your medications each month is $500. So if you look over in the third column, your monthly payment, you can see how that payment varies for the first 4 months. And that's based on how this is calculated. But you can see that for the remaining months, it stays the same. And you've paid $2,000, or you incurred $2,000 in drug costs by April, and you have no drug costs from May on, but you're making the payments throughout the year, and those payments do add up to $2,000. The next example is, again, the plan starting in January, and the cost of medications is the same every month, $80. Now here you can see that when you get into September and the later months, the way this gets calculated, you're actually paying more than the $80, with $241.53 being your payment in December. So if you know that your medications are like that, you may not want to enroll in this plan. And the last one is showing that you enroll in April and you have some erratic expenses for your drug costs. So you can see a lot of the months is $4, but in April, there was $617. But in April, you only had to pay $220.89. And then the cost goes down for the next couple months. And then in July, you had a higher cost again. So these examples just give you an idea. I know I'm going through this really fast, but I mentioned I'd be sending out an email either tonight or tomorrow. And the website, Medicare, that has these examples, that will be included in the link. So you can look at it more in depth and decide whether it might be worth your doing. And depending on your drug costs, it may, one of the things they say is to really look at whether you want to enroll this late in the year. It may be worth it, it may not. And, but if your drug costs are higher, you definitely would probably want to look at this for January. So I've got, again, the links here, but those will be in the website. And I just want to mention, those of us who are not on Medicare, that drug companies usually have programs that may assist with the cost of drugs. So Insmed, who is the manufacturer of brensocatib or Brinsupri, and they also, some of you may be on Arikayce. So they have what they call the Enlighten program, and we'll give you that link, but that may be a way of helping with costs also. One other Medicare option, if you have low income, they have what they call the Extra Help Federal Program. And again, that will be in the email that you'll get within the next 24 hours. And we're ready to go to the question and answer.
All right. So I'm going to start by going through the Q&A. There are several questions about a particular side effect that was noted in the clinical trials having to do with dental issues. So I'm just going to go through some of these. One of them that comes up is, if hyperkeratosis causes gum thickening and consequent tooth loss, can the gums be easily cut back and fixed? Will the teeth still fall out? And if so, what are the solutions, i.e. dentures? I'm not sure how much of that you can answer, but can you address the overall issue of the dental issues? You know, like how often was that observed? Were there any particular circumstances surrounding that kind of thing?
Yeah, no, great question. I should have dwelled a little bit more on the adverse effects. So unfortunately, I can't display the table that's in the New England Journal article, but I can tell you that the hyperkeratosis occurred in the skin thickening, 1.4% of the 10 milligram group, 3% of the Brenzo 25 group, and 0.7% of the placebo group. So that's the skin thickening. So not statistically significant across the three groups, the three arms. With regards to the periodontitis and the gingivitis, this actually was extensively studied in the phase 2 trial. All of the patients in the phase 2 trial had to have an evaluation by a dentist, and had measurements of their gums and were monitored during the phase 2 trial for any significant change in their gums and loss of teeth. And what was found in the phase 2 trial with this intensive dental monitoring, that there wasn't a difference in the three arms of the study. And so the FDA allowed the phase 3 trial, the Aspen trial, to go forward without specific dental monitoring. And the report in the phase 3 trial is that 1.4% of the 10 milligram patients developed periodontitis, 2.1 of the 25, and actually 2.7% of the placebo group. So as best we can tell, and of course, we really never know about adverse effects until the drug is more widely used, the dental thing is not an issue, and the skin thing is a minor issue. So hopefully that answers those questions. Yeah, hopefully that covers the main questions about the adverse effects.
Yeah, I mean, I think several people were asking, like, what can be done about it? I'm not sure that you can answer that. I think that's probably something more like a question for a periodontist.
Yeah, I mean, the way in the phase 2 trial, they had to do measurements of like their gum. I don't know all the technical terms, you're right, Amy, but they measured their gum thickness, and it was the general dentist who did it, not a periodontist, but that monitoring can be done by your regular dentist.
Okay. Okay, great.
Great. So we have a sort of a few questions in this one. If we try the DPP-1 drug, how long might it take to find out if it's having a positive effect on our lungs? If exacerbations are less of an issue, but lung function, low O2 numbers, and shortness of breath are the biggest problem, how might I need to see if the drug is having a good effect?
Yeah, no, that's a really good question, because it definitely does not work immediately. In both of the trials, it took like up to about 24 weeks, or between 12 and 24 weeks, to actually see an improvement in the exacerbation rate. Now, we don't really have that data for the symptoms because the symptoms were measured at baseline and at the end of the trial. So we are lacking in that data, but absolutely, if you go on this drug, you're not going to experience any kind of immediate positive result. It takes time for this drug to actually start to work in the airways, because its initial effect is actually on the bone marrow.
Okay. And this person is also asking if you would explain to help better understand how it can lower our inflammation, but still allow our immune system to fight off bacteria in our lungs.
Yeah,
And
no, right.
along with that, they say their inflammation numbers are really high. Doctors have stated this is due to bacterial infection in the lungs. All this inflammation has caused rheumatoid arthritis. Is there the possibility that Brinsupri, by lowering my inflammation, will help improve the arthritis issues?
Yeah, again, a series of really important questions that we don't have full answers to. But I think the first question is really the most important, because that's what came up when these trials are being designed, is impacting this part of the inflammatory cycle going to reduce your overall ability to fight infections? And it turns out that because this is very targeted to the lungs and works on only a specific inflammatory, the neutrophil elastase, there was no evidence of increased infections either in the lungs or systemically with this drug. But it is, the mechanism of action is interesting, right? It doesn't systemically reduce your ability to fight infections. It's very localized into the dealing with the inflammation in the lungs. But again, I put the caveat that we have to really see what happens in real life with this drug. When you think about it, only about roughly 3,000 patients have been exposed to this drug in trials, and in the small open label part that was after the trial. So more to come on that. The second question of like inflammatory markers, this is another thing that we struggle with in this disease, because patients do have increased CRP levels and SED rates just because of the chronic infection and the chronic inflammation. But we don't really have the greatest handle on, what those levels mean, and if they vary from week to week or month to month? Does that mean the inflammation is more or less active? Those CRP and sed rate are what we call biomarkers. And, in a lot of diseases, we have, blood tests that we can use to monitor disease activity. And we just don't have that here. We're working on it. But I would say Brenzo will not treat rheumatoid arthritis because it's very airway, lung specific. Will it reduce those biomarker levels? Probably not. Time will tell.
Okay. So we have a question. Is it safe to take brensocatib at the same time as Lexapro? And I guess as a follow-on, are there any significant contraindications with other medications that you know of?
Yeah, I'm not aware of any significant drug-drug interactions. But again, we're going to have to see in the post-marketing phase if there's any issues. But there's no, for example, like QT prolongation that we have with some of the other drugs we use in bronchiectasis, cardiac impacts. So the answer right now is no. But again, something we're going to have to pay attention to.
All right. So Dr. O'Donnell, I just want to let you know up front, this is not my question. Is Pulmozyme suitable for non-CF bronchiectasis? And if not, why?
Yeah, well, we did a study back in the late 90s in over 300 patients with bronchiectasis and looking at Pulmozyme, and unfortunately it failed to show an improvement. It actually made patients worse. If we revisited that today and picked a more like the treatable trait kind of patient that I mentioned, patients who are heavy sputum producers, we might have a different result. But unfortunately, that's the only data that we have on Pulmozyme or DNAs in non-CF bronchiectasis.
Okay. So we've had a few questions about the availability in other countries, including Canada, Finland, Europe. Can you just address if you have any information about, further clinical trials or studies going on in other countries? Because, I know that every country has its own approval process and requirements for clinical trials and evidence submission.
Yeah, my understanding is right now it's just US approved. I'm positive about that. It hasn't gone to the other agencies like the European Medical Agency or Canada. So right now it's just in the US. Will this company try to get it approved in other countries? Yes. I mean, the trials were done internationally. So the approval process will go country by country.
Okay.
In case of active chronic infection with Pseudomonas and bronchiectasis, would brensocatib be advisable? Or first, should antibiotic treatment to knock it back be attempted? And what if antibiotic treatment fails to control it? Can brensocatib?
Right. It goes to this question of how do you fit this drug into your treatment plan? And, in the trials, it was added on to standard treatment. So patients were not given a prescribed treatment. But my opinion is, you want to do all the normal things we do in bronchiectasis and then think if those things are not working, then add the Brenzo. But I think that's something also we're going to have to learn over time because there may be reason to put this drug in early. We just don't really know. But I do think you want to attack all aspects of the vicious cycle or vicious vortex. So this is clearly not an antibiotic. It doesn't kill bacteria. So, antibiotics are still going to be very important in the treatment of this disease.
Okay. Let's see. Okay, so we've okay, so you asked the Pulmozyme question already, right, Mary?
Yes,
I did.
Okay.
Yes.
So we've had a couple questions about were there PCD patients in the study? What about patients who have CF, because it was only non-CF patients in the study? Can you address like the sort of these underlying, and somebody else asked, like, if they have alpha-1, does this have any effect on their, alpha-1, on
Yeah, there were certain underlying diseases that were excluded in the Bronchiectasis trials. So cystic fibrosis was not, patients with that were not enrolled in this trial. Patients with immunodeficiencies were not enrolled in this trial. I believe I'd have to double check that we had well, yes, I know we had PCD patients in this trial. Yeah, so certain, each trial has approached this differently. Many of our trials have excluded immunodeficient patients, although that's loosening up now that if you're on replacement therapy, you can get into a trial. In terms of the CF question, the BI drug that I mentioned to you is going to take the one bronchiectasis approach, the phase 3 trial, the Activity trial, and enroll both non-CF and CF patients. So yeah, there were some exclusions in these trials, but it doesn't, so we can't say if it's going to work across the board in every patient with bronchiectasis. Alpha-1 antitrypsin was not an exclusion.
It wasn't. Okay, one of the questions we have about alpha-1 is could brensocatib or DPP-1 inhibitor help alpha-1 patients who lack the alpha-1 protein, which helps inhibit neutrophil elastase and lung damage?
Yeah, great question, but I don't have the answer to that.
You don't know. Okay.
Yeah, we don't know.
So I was at the PCD Foundation conference last week, and they actually did mention the breakout of PCD patients in the trial. My math may be wrong, but I think there were 118 PCD patients enrolled and somewhat evenly distributed against all 3 arms. A little heavier in the 10 milligram arm, but. All right. Will there be any studies with this drug that will have patients both with NTM and bronchiectasis?
I don't know the answer to that. Of course, how the company or the other companies looking at this type of compound will push forward with other indications is unclear. I mean, clearly the NTM, which many of you are interested in, and I am very interested in, is something we really need to understand better, because there's reason to think this drug would probably help, but we just don't know. And because the endpoints of these trials are all about exacerbation reduction, the primary endpoints, and people with just NTM don't really exacerbate very often in the classical sense, like per that definition. It's unknown right now.
And so for is it Activity study?
Yes.
Is NTM an exclusion criteria?
Yeah, NTM on treatment on NTM antibiotics is an exclusion.
Okay.
Yeah.
Thank you.
I mean, I do know that currently brensocatib is in clinical trials for other indications. I know they're looking at it, I think, for hidradenitis suppurativa, which is a skin condition, an inflammatory skin condition, also for chronic sinusitis. So, these drugs are going to be looked at for other inflammatory conditions as well. But
yeah,
I guess the question of using it in patients with an active MAC infection or active NTM infection, I think that's probably going to come, as the drug starts to get used more. If you have a patient, if they have an infection and it's relatively stable, but they have some kind of bronchiectasis exacerbation, if they keep having exacerbations, it might be considered. I don't know.
Yeah, that's one of the things we as investigators should probably push to analyze because, you know, once the drug's on the market, I don't believe the FDA mandated any kind of definite phase 4 post-marketing study, but it is something we in the investigator world, and with your help, Amy and Mary, you know, advocacy wise, we really need to find out.
This is an interesting question, and I think this is something that I think there's a lot of conversation about with patients. So the question is Brinsupri an immune suppressant medication? And I'd like to, you know, go circle back to this and address it specifically, because it's being described sometimes like that, and I think we should address that because this is a novel compound. So
yeah, so it's, you know, the thinking is it's very locally anti-inflammatory, not really, because you know the ability to fight infection is a multifaceted immune response, right? I showed that slide that has all those, that cartoon that has all those like different active interleukins and macrophages. And so the thinking is this is very specific, and that's why it's, number one, not a systemic immune suppressing medication. But I mean, that being said, you know, I've pointed out in that one case that, you know, I would be a little concerned, cautious about using it in patients who are immunosuppressed, because again, we don't really know completely about this. I mean, the thinking is it's very lung specific and anti-inflammatory more than totally immune suppressing, but it remains an open question, I would say, particularly to use it in patients who are immunosuppressed, say on a biologic for an autoimmune disease.
okay.
If taking another biologic for asthma, Dupixent, is it potentially appropriate to add brensocatib?
Yeah, that's another. Now, you know, if you're on if you're on an asthma biologic for your bronchiectasis, generally you have the more eosinophilic type bronchiectasis, the more allergic or asthmatic-y bronchiectasis. And this targets neutrophilic inflammation, although probably in most patients who are thought to be mostly eosinophilic, there's some element of neutrophilic inflammation. I would be cautious about that. I think we just need more experience with the drug. But if you're a patient, again, this is just general thinking here on my part, my opinion. If you're a patient on a biologic and it doesn't seem to be reducing your exacerbations, you know, that's a conversation you need to have with your physician about whether you need a different asthma biologic or, you know, convert over to this drug.
So we have another question that's just sort of asking, can you please expand on the following? Will brensocatib slow bronchiectasis progression, improve lung function, lessen lung destruction, lessen exacerbation, and lessen infection risk? So
yeah, we want it all there.
I mean, well, yeah, you know, reach for the sky.
Yes, absolutely. So based on what we know from the trials, right, we know that it improves symptoms based on that quality of life questionnaire, and it slowed the decline in lung function. You know, every year as we get older, our lung function naturally declines, so it slowed the decline compared to placebo. But it's an open question. You know, this is something I'm very interested in, to if we could, you know, identify patients, say, with very early bronchiectasis, would this drug have a role in preventing progression? I mean, I absolutely don't want you to leave this seminar thinking I said it would. I'm just saying that's a question that's a very important question, and it goes to that bigger picture of how do we identify patients much earlier in their disease before the vicious cycle has really taken hold. And, you know, is there a cohort of patients, like the patients that get picked up incidentally with bronchiectasis because they've had a, you know, coronary CT? Would there be a role for looking at this drug here? again, I'm just totally speculating here, but those are important questions that we really don't know the answer to.
All right, thank you.
Is a higher than normal neutrophil reading indicating that bronchiectasis is acting up? And
Yeah.
if the reading returns to normal, does that indicate that airway clearance is working?
Oh gosh. Again, it goes to that fact that we don't have a great handle on these so-called biomarkers, blood tests to look at disease activity. So although for asthma and for eosinophilic bronchiectasis, we look at the eosinophil count on the peripheral blood, CBC, we really don't know very well if the neutrophil count correlates with neutrophilic inflammation. So right now, the answer to that question is no, it's not an adequate biomarker. And gosh, I wish airway clearance could be measured by the level of neutrophils. That would be great. Even doing a test like, in these trials and in the development of this class of drugs, a lot of emphasis was put on sputum neutrophil elastase levels. And I showed that one slide in the phase 2 trial where they go down with the drug. But that's not something we test clinically. We don't measure neutrophil elastase in the sputum in clinical practice. So again, we have so much more to learn really, and how we can help our patients and how we can prognosticate how things are going to go for patients based on these kind of tests. We really, really need more information on that kind of thing.
Somebody's asking about the exacerbation rate. So if a patient has a severe bronchiectasis, but they have less than 2 exacerbations per year, are they're not a candidate for brensocatib, even if they're based on the severity?
Yeah, so the FDA, in their approval label said it's just for bronchiectasis. They didn't specify a number of exacerbations that needed to be recorded prior to starting it, which is kind of interesting because the trials all use that 2 or more exacerbation per year to enter patients in the studies. So, it's to be seen yet, how insurers are going to view that. But according to the label, it can be used without a history of exacerbations. Clinically, I'm not sure I would do that, prescribe it for that. But and it's also noteworthy that the new phase 3 trials and the other neutrophil elastase have different entry criteria. It's 1 exacerbation. It's 2 or more exacerbations, or 1 exacerbation plus a high symptom score to get into those into that BI and Chiesi trial that are coming.
Okay.
Could you ask the next one?
Yes, I can ask the next one. Somebody's asking, when you start brensocatib, how long on average did it take for patients to start seeing, an effect, a positive effect?
Yeah, again, the exacerbation rate started to separate at week 24 in the Aspen trial, the phase 3 trial. We don't really have the symptom score thing was at baseline and at the end of the trial, so we don't have a good readout on symptoms, as to when they start to, or if they start to improve.
Okay. Somebody's asking about one of these side effects of upper respiratory infections. Do you have any, information about any other information about that? Is there like anything significant about that, or was it?
Yeah, and that's an issue in all of these trials that we've done. I'm just pulling up the page here, but it's like, is that just the disease itself, or is it a side effect of the medication? And that rate of respiratory infections was the same across the 3 arms. Actually, the rate of COVID infection was the same too. So I would say that's more the disease itself in these trials rather than a side effect of the medication.
Okay. I also, there's a comment here from somebody, they've just they've just received brensocatib. They've had both NTM and bronchiectasis for many years. And I think that probably tracks if you've had NTM for many years, but if you have bronchiectasis and the bronchiectasis exacerbations are what they're looking at for the prescription. So if you're having more than 2 exacerbations a year, that's, I think, going to be sort of the baseline for deciding on prescribing it, correct?
I mean, that's where I stand on it because
Yeah.
that's where the data is. But the FDA made the indication quite loose. But
Okay, so they left it open for, yes, if
for
some.
clinical judgment.
Yeah,
Yeah.
they didn't say to exclude NTM patients in the final label indication. They said it just, so they didn't have any, they didn't weigh in on it one way or the other then. That's
Correct.
okay, that's good. It's good to know. Um, Here's an interesting question. Between the 10 milligram and 25 milligram doses of Brinsupri, are you noticing one being used more often in practice, and does that line up with the recommendations? That's an interesting one.
Yeah, well, the drug's only barely available, so I don't have any data on what people are prescribing. The results were quite similar. So is there reason to go with the lower dose? The FDA approved both doses. We have experience. I personally have experience with patients who were in the open label access after they were part of the clinical trial, and that dose was the 10 milligrams. So honestly, I can't answer that. We don't have any data yet because it's only been available for a week or 10 days. But it'll be interesting to see in the post-marketing how that shakes out if that data becomes available.
Okay. So here's another question. We know the drug reduced exacerbations, but what about daily coughing up mucus? Was there anything in the data from the studies about the mucus production?
Yeah, again, it was this composite questionnaire that it's called the Quality of Life Bronchiectasis, which does include like a question about sputum production, but otherwise we don't really have a good answer to that. Does it truly reduce the volume or the purulence, or we don't know.
Okay. We've had a couple of additional questions about exacerbations. So one person was saying that a lot of times they experience a fever with their exacerbation, and that wasn't included in the criteria. And then somebody else is asking, can you please describe an exacerbation? Can you go through that description again? I think it's an important point just because of the criteria for this drug.
Yeah, fever is one of the criteria. If present for more than 48 hours in that composite definition we have of exacerbation. So it does count towards the total, change in cough, change in your sputum quality or quantity, hemoptysis, fatigue, and shortness of breath. Again,
Okay.
that definition is something we came up for as endpoint for clinical trial, but it's useful in clinical practice to have some ability to define it and make patients aware. Yeah.
Okay, yeah, that makes sense. Yeah, so because we had somebody else who just commented about increased nasal discharge, which I suppose could also be, something, but I think probably patients have some people might have different additional symptoms.
Yes.
So here's a good question. Bronchiectasis is the lung condition associated with diverse physiological states like COPD, asthma, or infection. Does it present the same way for all these causes, or could you look at bronchiectasis and say, this looks like infection, or this looks like emphysema, or this looks like COPD or asthma? So are there ways to differentiate it, or is it just that you look at it on a CT scan and say, this is bronchiectasis?
Yeah, so the CT defines the anatomic abnormality of bronchiectasis. It sometimes can help us with the cause, but often doesn't, and then we have to dig deeper in terms of the patient's history. Had they had prior infections? Did it, and do lab work to look for things like, rare causes like immune deficiency, alpha-1, congenital disorders. So the CT confirms that you have that, right? But it doesn't tell us, the bacteria. It doesn't tell us, what the cause is. It may lead us in certain directions, but it doesn't actually confirm anything other than anatomically your airways are abnormal.
Okay.
Great. Amy, we are a little past 4.
We are.
I want to thank Dr. O'Donnell for her time, for being here with us today. We do have a lot of questions that we weren't able to get to, and we'll see how we can get those answered, because we know there's a lot of interest in this drug, and there were some other questions also, not related specifically to DPP-1 inhibitors.
So these
If you
questions have
haven't-
given us a lot to think about more studies that we need to do. So really appreciate the thoughtfulness of all the questions. Thank you.
Yeah. And
Yeah.
if you have questions that are related to airway clearance specifically, please don't forget to sign up for the September 10th webinar with the Yale specialists. That is a good place to ask those questions.
Yes, and we'll have that link in the email that'll go out within the next 24 hours.
Correct.
So thanks everybody again. And thank you, Dr. O'Donnell. And look forward to our next webinars together.
All right, great.
Thank
Thank
you,
you so
Dr.
much,
O'Donnell.
everybody. Yep.
Thanks.
Bye-bye.
Bye-bye.